And just before we start this session, Ellie and I brought a small gift from Australia. So this is a boomerang. And now boomerangs are famous because they always come back. And we thought this was a very appropriate gift because we hope that we boomerang back to India very soon. So I'd like to present this to Dr. Singh. And this is a traditional Australian boomerang. It's for you. Yeah. Thank you very much. Thank you.
No worries.
Now, please don't throw it because these are used for killing kangaroos. So don't throw it inside. Yes, but this is ornamental. Yes. So you don't have to. Yes, if someone is late to the sessions, Dr. Singh will be out with the boomerang to round you up. Yeah. Thank you very much. Thank you.
Okay, so this session, we're actually going to use some cases to really highlight what can go wrong. And then I'm going to let Chris step in and show you how to actually, hopefully, not have things go wrong. This is a case that presented to our hospital a few years ago now. And I'm going to introduce, I'll just get my click. So this is Rayu. He's a 1-year-old, 9-month bull terrier, very much loved. But he only had one testicle come down. His owner knew that this needed to be addressed, and so she booked him in at her local vet's for a castration. The anatomy in there, which I'm going to leave a lot more to Chris, is, and I've been here, I've been doing cryptorchid castrations, and you get in there and you can't really see what's going on. You might get some oozing from your linea alba. It all gets a bit daunting. This poor vet actually thought they'd found what they thought was the cryptorchid testicle, but removed the prostate. So this case then got transferred to us when they realised something was, they did realise post removing the prostate, something was wrong. We were left with a bladder kind of floating in thin air here almost, so both ureters had been transected and the prostate fully removed. So we had the urethra down in the Netherland and a bladder floating in thin air. Briefly, our surgeons were able to actually get back in and plumb in the ureters back into the bladder. We had to maintain a urinary catheter in this dog while he was healing. We were very, very concerned about the viability of his bladder, what blood supply we had, whether those ureters were going to retake in without any complications. And he was critical. This is how he looked post, so they'd managed to get the bladder. They'd had to go into the bladder to do all of this. And some of the colour of the bladder didn't look great, but we had hope for him. We were going to try. The things we were watching post really closely in ICU, we were watching what his bladder was doing. We were monitoring wall thickness. We had a urinary catheter in him as well. We were looking for free abdominal fluid to see if there was any dehiscence or breakdown. We were getting a uroabdomen, and we were watching his blood work very closely. We were monitoring the size of his ureters to see and monitoring any trends in those throughout his hospitalisation, and also his renal pelvis dilation. He ended up needing a revision surgery. One of the ureters had granulated and was obstructing, so we were picking that up in a more and more dilated ureter and a more and more dilated renal pelvis on that side. He did go back to surgery. I just want to quickly show you a couple of videos because he was very cute. This was the owner teaching him to pee. She was post and had his urinary catheter out. We were wanting to void his bladder by himself. He was a very stoic dog. He was a very good dog in hospital. He ended up being in with us in and out over about 3 weeks and then continued rechecks. We were very lucky and he did have degrees of azotemia along the line. This was what kind of his go home rate that we ended up with him back down to. He ended up incontinent and had to wear a modified nappy for the rest of his life, but he was alive. And these owners were very lovely. They understood mistakes happen. They were very kind to this referring vet. They didn't take it to, we have a vet surgeons board. They didn't take it to the board and make formal complaints. This vet came and spent time at our hospital and got confidence back again, doing cryptorchid, doing with the anatomy, and spent time with our surgeons. So I guess to try and avoid you guys going through something like that, medical errors do happen, and they can pull apart a vet. They can have vets who actually change profession. We're the middlemen often in referral settings of helping these referring vets through these cases with communicating with the owners, and having them, no matter what, they beat themselves up and they feel such guilt and shame. But it's something where, little steps can help prevent big mistakes that can end in a life not being able to be compatible with life. If he had a dehist, we couldn't have got him back together, he would have been euthanized. So I'll hand over to Chris, and this is a lecture which I've been lucky enough to do with Chris before, and I'm forever grateful for how well he can describe this, and I even came away a bit more confident. If I was to ever to go back to my surgery days, I think I could give it a good go. So thanks, Chris.
Thank you, Ellie. You're too kind. So mistakes and complications are hugely confronting, and it's a reality of what we do. And we thought it would be important to present a case like this to discuss the realities of what happens when things go wrong. And what Ellie described here is the perfect scenario for creating that second victim. The vet that made this mistake could easily, become the second victim. They could easily be ostracized by the vet community as someone who was negligent and did a terrible job. The reality is, rarely does anyone ever set out to make a mistake or to do things wrong. To embrace that growth mindset means that sometimes we have to reflect on things we've done. And I showed you some cases where I've told you this is not how I would do it now. And to change and to improve means actually looking back and saying, perhaps what I used to do wasn't the best thing. Now, it was the best thing we knew at the time, and it was the best thing that we did with your level of knowledge and understanding. But as we grow as a profession, I think it's so important we embrace this change and improvement to say that it's not that we did bad things in the past, but simply we did the best thing that we did at the time with the current level of knowledge. And it's people like Ellie and myself that have failed the profession if things are not changing, because we all know that we do not have 100% success rates. And if we want to improve our outcomes, it will mean embracing some of this change. So this is how I think about complications, is that we do the best we can at the time, but sometimes that isn't quite enough. But again, we're looking always to improve. And so I like giving this talk because I think here, understanding that anatomy, that roadmap, can help us overcome some of these problems. And can I have a show of hands? Who here has removed an abdominal testicle? Show of hands. Okay. Great. Leave your hands up if you really enjoyed that experience. Was it good? So a few of you, and I bet you those people with their hands up know exactly what I'm going to say. Because, again, I have actually had endless free lunches with this, because when I teach at the university, students often come and they think this is a terrible procedure. We know from the literature that this testicle could be anywhere, and they think this is going to be a hunt. And I say, you'll find this testicle within 5 minutes. Otherwise, I have to buy you lunch. And if you find it within 5 minutes, these are students, you owe me lunch. And so I've had many, many free lunches, and I'm tight. I've never had to buy one. So using this technique, what I would say is that, of course, you can use ultrasound to try and find this testicle. But it's a bit like a needle in a haystack. It's difficult and it's hard. And so I have a standard approach to how I approach the cases where there's only one descended testicle. The first thing, I go for the simplest thing. You know me by now. We're just going to palpate the scrotum to see maybe it's small, maybe it's still there. Then I go to the inguinal area, because many are sitting in the inguinal area. If you are not sure whether what you're feeling in the inguinal area is a testicle or not, I like to use ultrasound. I'm not a good ultrasonographer. This is the one thing that I will ultrasound. And it's very good because you've also got a control, often the descended testicle. So if you're unsure, you can scan that as well. And so what I do, and I'll show you this picture. This is from when I was doing coaching and I travelled to a town called Bathurst. And Bathurst sits a couple of hours from Sydney. And here is one of the vets here. She's ultrasounding the inguinal area. And what you can see on screen is the testicle. Now, the testicle looks like a big oval with a really bright line in the middle. This is the rete testis that we see here. So it's very distinct. And as I said, if you're not sure, you have ample of numbers of cases that come in that you can ultrasound the testicle in the scrotum to check so you know what it looks like. You can scan every patient until you're comfortable. But I like to check before I make an incision in the inguinal area, because this is what I call tiger country. Once you get down in this area, there's lots of vital structures there. You want to make sure that you're right on top of the testicle. You don't want to dig around in the fat. So the first port of call is the inguinal area. Check with ultrasound to see if it's a testicle or not. If it is, we simply stabilise it with our fingers, make an incision right over the top of that, and treat it like a normal open castrate. So that's relatively straightforward. If you can't feel it in the inguinal area, so this is quite a common scenario, one testicle or no testicles, can't feel anything in the inguinal area, then it's going to be in the abdomen. Now, this is not exploratory surgery because we know what that's attached to. We know the testicle is attached to the vas deferens. We know the vas deferens will insert on the prostate. And so we think about what's the fixed anatomy and what's the mobile anatomy. The fixed anatomy is the bladder and the prostate. The mobile anatomy is the testicle. It could be anywhere from the kidney right down into the scrotum. But we're going to cheat. We're going to go to the known anatomy first. And so we make a caudal midline celiotomy. You find the bladder. I think many of you will be confident doing that. You retroflex the bladder. Now, that's not what we do if we do a cystotomy, but we pull the bladder back. And what you see are two white structures coming out, running forward, and these are the vas deferens, and they wrap around the ureters. So let's have a look. This is a cadaver specimen. And if we look at this image here on the left first, what you can see here are the two ductus deferens, one here and one here. And they run cranially and then they wrap around here, these lateral ligaments of the bladder, and this is the colon sitting below. If you pick that up and trace it, if it's descended, it will come out and go through the inguinal ring and out to the scrotum. If it doesn't, then you'll follow that along like this, here, and you'll see at the end of that is our intra-abdominal testicle. So this is the secret. To go in caudally, find the bladder, retroflex it, find these paired ductus deferens and follow them both. This is a clinical case here. You can see we've got just a caudal celiotomy. This is the tip of the prepuce here, so you can see how caudal we are. Here is the ductus deferens here running to the testicle here. And this is actually a case that came in to see me last week. I do about one castration a year. So I was very thankful when I was coming here to this trip, giving this talk, that this animal presented to me. And the owners wanted a specialist surgeon to do this procedure. Now, I want this to change because I want every general practitioner to be able to do this surgery confidently. The owners shouldn't have to find specialist surgeons to do this. But in saying that, if the veterinarians are not confident, then again, we've got room for growth improvement. So what I'm going to show you this little video here, I find the ductus deferens, here it is. I don't know where the testicle is at all in the abdomen, but if I follow it through, then lo and behold, there it is, right at the end. So I think of it like, having a bit of a rope and, pulling in the life ring or something if you're a lifeguard, and at the end of that will be either your drowning person or your testicle. And so from there, it's just a simple case of performing that castration. You deal with the vessels, then you ligate the vas deferens. So that's a simple way to perform that cryptorchid castrate. But there is always one extra thing. And so life would be just a little bit too simple if this is all there was. So there is one other place where that testicle can be. And we said the mark of a really good surgeon is you know how to access all areas. It's like the backstage pass. You need to know how to get to every part from that kidney all the way down to the scrotum. So we talked about how you manage the groin area, about how you manage the intra-abdominal area. Now I want to talk to you about the mysterious inguinal canal, or the inguinal rings, because rarely does anyone go here. The two reasons I go here are cryptorchid castrates and inguinal hernias. So I want to talk you through the anatomy here of what the inguinal ring is. Now, in the textbook it says this is a virtual space. That's correct. I don't know what it means really, but it's correct. And the way I think of the abdominal wall is like having two sheets of paper. Each piece of paper has a hole in it. So the piece of paper on the top has a hole that's called the superficial inguinal ring. The piece of paper underneath has a hole in it, and that's the deep inguinal ring. But when you put the two pieces of paper on together, those holes don't line up. And so what you've got is this virtual space between those two pieces of paper, which is your inguinal canal. And so you can access this area if you know how. So again, if we look here, what we've got is the external side here on the right. And this is the superficial inguinal ring. This is a split in the aponeurosis of the external abdominal oblique muscle. So that's the piece of paper on top. It's a slit in the muscle. The deep inguinal ring is a gap between muscles. So it's a gap between the rectus abdominis, the internal abdominal oblique, and this inguinal ligament. And so that's important because you can suture that superficial inguinal ring, the slit. You cannot suture the deep inguinal ring. The deep inguinal ring is just a gap between muscles. So if we're trying to close that space or access the space, you access it from the outside. You can't access it from inside the abdomen. So what passes through that inguinal ring normally? Not a lot. So the descended testicle will pass through that, and then we'll also have the caudal superficial epigastric artery and vein, and then you've got this external pudendal artery and vein. And so really the size of this gap only needs to be small. If it's too big, we get an inguinal hernia, but when we're dealing with this, we've got to recognise there's not a whole lot that goes through here. So this is a clinical case. And what I've done, you can see here in the fingers I'm holding the ductus deferens. Now, as I trace it, it looks like it goes through the deep inguinal ring. But then when I look in the inguinal area, there's nothing there. So this is the one scenario where it can be a challenge because that testicle sits between those two pieces of paper. It's sitting in that inguinal canal. And so how we access that is then to create a little slit. So we take that superficial inguinal ring and we make that bigger. So that little slit we extend cranially until the testicle pops out. Let's have a look first of all here. So we're pulling it. You can see there's nothing in the groin here. So you can see you can almost make out there's a little sort of bulge there in the wall. So you can split along those muscle fibers until the testicle pops out. And what you've done is that top piece of paper, you've just made that hole a bit bigger. And so once the testicle is out, you then ligate it as you normally would, and then you're going to close it down. And you close it down. It's really dense connective tissue, lots of collagen, good to suture. It's like closing the linea. But you're going to close it from cranial to caudal. And you only need enough gap until those vessels can pass through. So I just do it until you can't put your finger through. Because if you don't close it, the risk is that you could create an inguinal hernia. Now, I talked to you yesterday about building competencies and building these procedures. If you are comfortable with doing cryptorchid castrates, and you might pick up a handful of these, then the next step is to proceed on to inguinal hernias, because inguinal hernias are, again, very challenging. There's a whole lot of complex anatomy here. But if you're familiar with this and have the competency to identify the inguinal ring and to suture that, then you should feel comfortable moving on to inguinal hernias. And this is sort of how we grow as surgeons, is you build your skills incrementally, and if you chunk down procedures, then the closure for this is the same as the closure for an inguinal hernia. So you can sort of get an idea of here, this is how we grow as surgeons. So really the take-home message here is that mistakes can happen. We need to reflect on them and understand why. The best thing is for you to all take away the mistakes that Ellie and I have made. And learning from our mistakes means you don't have to make them. My mentor had a saying that I'm allowed to make mistakes. I'm just not allowed to make mistakes that he's made before and told me about. Because he said, you will find new and inventive ways to create complications. And that was very true. And so again, as we move this profession forward, it's learning from previous generations and the mistakes that have been made, passing that information on. And again, you will find new and creative ways to make things go wrong, but again, that will launch that next generation. So we're all going to learn from our mistakes. Anatomy is our roadmap. That is key. If things look wrong intraoperatively, don't proceed on. Stop, backtrack, find your anatomy, and then move forward. And if the original surgeon, in that case that Ellie presented, had done that, then probably there would have been there would have been warning signs that you weren't in the right place. It sounds like a how could you do this? One of my very best friends has also made this mistake as a new graduate. Probably one surgeon every year makes this mistake, and it's almost always a new graduate. And so the other thing that's important is integrity and accountability. Now, as a surgeon, no one often sees what you do. If something goes wrong and this young surgeon identified something was wrong, you can then action it. That takes a really big person to say, I've made a mistake and now I need help. But if you don't do that, then the outcome for your patient is likely to be very poor. So a really confronting case, really sometimes difficult to swallow these cases. But again, prevention is better than cure. And again, I hope these have given you some insights into how we can prevent these complications occurring. All right, thank you very much. Now, we may have time for a quick question or two before we move on to our GDV discussion. I see there's a pressing question at the back. So get a microphone there. Do you want to come to the front and I can probably then hear you? The incontinence? Yes, after which procedures, sorry? Yes. Yes.
In all, male or female,
Yes.
either of case, we encounter urinary incontinence.
Yeah. Generally, we don't see a large number of episodes of incontinence after these surgeries. I think one of the possibilities may be increased tissue damage. And so if you're doing excessive dissection and potentially affecting some of the nerves, or if we're causing more tissue trauma, then we may see incontinence. I think the secret to minimising and preventing that is, again, gentle tissue handling, going in just doing what you need to do, not dissecting dorsally in particular. Now, I guess what we do see very frequently is stranguria or increased frequency of urination, but a true incontinence, I think, may suggest that we've had potentially damage to even the nerve structures. So I would be a little bit careful with that. It may be too much stretching or retraction. But if it's just increased frequency, that's quite normal. Yeah. But I would say gentle tissue handling, not too much retraction, should help with that. Otherwise, time and supportive care will help.
Okay. So even after doing castration, ovarian stroking, could it be a hormonal issue?
So longer-term incontinence potentially. So in females, you can get a urethral sphincter mechanism incompetence. So if you're doing very early desexings, then yes, development of incontinence can occur due to hormones.
Thank you. Thank you.
Time for one more quick question.
Topics is urinary emergencies. We have not discussed about the emergencies in cat, penile lower urinary tract disease. This is a very, very emergency.
Yep.
Obstruction or any other. There is no urinating, only straining is there. This is a very emergency.
Yep.
And what is your view or?
Yep. So feline lower urinary tract disease, inflammatory disease, can cause often lots of straining and stranguria. It can be associated with obstruction, so we get lots of small sediment that causes, particularly in male cats, an obstruction. You treat them in the same way, so I use a Tomcat catheter, retrohydropulsion, and then flushing of that bladder. Now I flush lots and lots of saline through that bladder because I want to remove the sediment. Because if you don't empty that bladder of all that sediment, then reobstruction is likely. Now generally the underlying disease is often dietary, and so these animals have crystalluria, and these animals have recurrent episodes. So it becomes more of a medical issue in terms of long-term management, The surgery role is really one to unblock those cats, but in fact in Australia it would be Ellie and her team that would generally see most of these cases. Urinary catheter to relieve the obstruction is of utmost importance, but then it becomes much more of a long-term management issue. The perineal urethrostomy creates a bigger hole. It may prevent the obstruction. It doesn't cure the underlying disease. So they will still form stones, they will still have cystitis, and they will still often have these episodes in the future. But if you do a perineal urethrostomy, the chances of ascending infections are much greater. So then you have a new element. So perineal urethrostomy is not a cure for feline lower urinary tract disease. It's a way of helping manage that to avoid the life-threatening emergency, but it creates new complications that could occur for that cat. So that's how I would approach it, but we have to think of it more globally, that it's a disease, with those cats that will, for their whole life, will remain prone to that condition.
This is one of the stress.
Yep.
Stress is the one of the factors.
Stress, 100%, yes. So there's multifactorial, but this is not necessarily my area of expertise, I'm afraid, because often we have other clinicians that will manage these cases. So I'm probably not the best person to comment on it. So that's why it's not so much in this particular talk.
Thank you, sir.
Thank you very much.
Excuse me, sir. So we have here. So we have cases of urethral strictures.
Yes.
So how to deal with this, especially in puppies? So we found puppies on the roadside, crushed by the automobile vehicles and everything.
Yes.
Sometimes they present to the clinic with a bladder rupture.
Yes.
And sometimes there might be a possible urethral stricture also.
Yep.
So we can't do the cystoscopy and ballooning. All these procedures can't be happening in this case. So how to deal with these cases?
Yeah, I mean, strictures are very difficult to manage. So they can occur post-trauma. If you have a severe stricture, the only option you may have is to resect out that stricture, and that can be technically very demanding because, again, the tissue is not necessarily dilated and it's small and very fine. So resection and anastomosis is possible. The alternative is diversion. So depending on where the stricture is, you may do a urethrostomy upstream of that so that they can urinate before that area of stricture. I guess it's generally unusual to have sort of two areas of pathology. So, bladder rupture and then getting a urethral injury, because normally when something breaks, one bit goes and that relieves the pressure. But urethral strictures, can be difficult. I've never tried to balloon them or anything like that. Prevention is, if you see these cases early, so atraumatic surgery, opposing mucosa to mucosa is important to prevent that stricture. Because if you've got a gap between the tissue and you get scar tissue, the scar tissue contracts, and that's what causes the stricture. So if you can see these cases early and perform surgery to get mucosa to mucosa apposition, that'll minimise the risk of the stricture forming. Once you have it, though, your options are limited. It's really diversion, or it's going to be resection if possible.
And one more doubt. So what are your thoughts on Gus cystotomy? In these cases, Gus cystotomy help us anyways?
Does a cystotomy help?
Gus cystotomy.
Gus cystotomy, I'm not familiar with it.
GUS, Gus cystotomy. It's like a port which we directly connect from bladder to the exterior body wall.
Right, okay. So yes. So yes, I would sort of term these low profile cystostomy tubes. So that's another option for animals that have someone to care for them, is that permanent diversion is possible. And so this would be the equivalent of humans having the bag that collects the urine. Dogs can have a similar thing, but we don't generally have it collect in a bag. We just get the owners to periodically empty it. So if you have a dedicated owner, in many cases where you have irreparable damage downstream, that's an option.
And in these puppy cases, sometimes the urethral rupture will be inside the pelvis.
Yeah.
So can we cut open the pubic symphysis and correct the urethral rupture and can we do this procedure in puppies, because it's just a growing puppy?
Yeah.
So can we sacrifice this pubic symphysis to correct this urethral rupture?
I guess the answer is yes, you can, but I guess this now gets into the category of how much are we asking this patient to go through, with what likelihood of success. But this intrapelvic urethra is a very difficult area to manage. It's rare to get true trauma there unless it's secondary to a fracture that lacerates the urethra, because normally the pelvis provides, quite a nice protective cage. So unless it's secondary to fracture and laceration, you don't tend to see that area affected too much, but it's possible.
Thank you.
Thank you. Now maybe we might move on to the GDV, because